if I can remember, his first talk to the forum in 2009, and ever since then he has been a regular at the forum. Sir is a wonderful neurologist. There is a long introduction to Dr. Puneet Agarwal. I'll just keep it very short. His first love is stroke, his second love is stroke, and his third love is stroke. Dr. Puneet Agarwal sir is a senior neurologist, head of unit in Max Saket, and always accessible as Dr. Viveka sir, and very friendly with almost, I would say, all the members of the forum. Over to you, sir, for your talk.
Thanks, Dr. Chauhan. So first I'd like to give thanks to Dr. Sushil for organizing, I think it's a wonderful event for this occasion of birthday of our Honorable Prime Minister. And I think prevention is always better than cure. So it's I think it's a nice theme he has chosen on this day. And I'd like to give thanks to Dr. Chauhan also for giving a nice introduction. So I'll also don't take much of time. I think Dr. Prashant has beautifully told about the lungs. So brain is also very, I think, one of the most important part of the body, and prevention is important to how to save brain. And I'll basically speak on how to prevent the brain attack, that is stroke, which is the third leading cause of death, as all of you know. So if you see the data, every 6 seconds one person is dying from stroke or brain attack. The problem with the brain attack is the awareness for the brain attack is very less, especially in the public. And we know that nowadays there is a golden period which has extended from 6 hours to 24 hours in selected group of patients, in which the patient comes from the onset of symptoms within 24 hours. We can do certain interventions, we can give clot busting injections which can improve the patient remarkably and save the life of the patient. And the time is always very important when we are dealing with these patients to prevent the brain from dying from brain attack. Per second 32,000 neurons, and per minute around 2 million neurons are dying. So each minute is important. Even in Max Hospital we have a very aggressive stroke program, brain attack program. Any patient coming to us, the door to needle time in our setup is ranging from around 22 minutes to 45 minutes in most of the cases. Now coming to the prevention, as all of you know, for the brain and the heart the prevention is almost similar. Risk factor, you are aware of that: hypertension, dyslipidemia, diabetes, obesity, sleep apnea, smoking. Dr. Prashant has told a lot about that. Alcohol, carotid disease and cardiac disease. So these are the risk factors which we come across, and we should be careful while dealing with the patient to prevent the brain attack in these cases. So out of that, the principles of brain attack or stroke prevention stays live with the introduction or application of statin, antithrombotic therapy and blood pressure management, which are the most important besides the other risk factors which I have told you. So I just emphasize on the major risk factors. So hypertension is one of the most important risk factors, and according to the AHA guidelines 2018, which is the recent guidelines followed, that the target blood pressure in a normal person, in a person who is not having other risk factors like diabetes or having a family history of atherosclerosis, in those cases usually target is around 140 systolic and 990 diastolic. It should be less than that. So there is a class 2A level B evidence. But patients who are diabetic and who are having or patients who are having a severe atherosclerotic disease, having a renal disease, in those cases target is less than 130 by 85, and that's a level 2B, level B and class 2B evidence for the prevention of brain attack. So if we see that in hypertension, the recent guideline says that systolic should be less than 140, as I have told you. This is the level A class 1 evidence, and patients who are high risk cases, especially diabetes, kidney diseases, renal disease, in those cases the target is less than 130/80, and this is level A class 1 evidence. The cigarette smoking is as injurious as for the lung, as Dr. Prashant has told in detail. So I am not going to detail about that, but for the brain attack or stroke also, the cigarette smoking it leads to a 5 times risk of developing stroke. So if there is a level B, a class 1 evidence that there should be abstinence of every patient who is having a history of smoking, or who is having a history of smoking, and who is having other risk factor for developing stroke. In terms of diabetes, so every patient who is having diabetes, the chances of developing the vascular atherosclerosis as well as the stroke increases, and the control of diabetes as well as the control of the other risk factor like blood pressure, hypertension, cholesterol, dyslipidemia is very essential in these cases. There is a level A class 1 evidence. The treatment of hypertension in diabetic, as I told you, the target should be less than 130/80, and the diabetes that should be treated aggressively in all these cases to prevent the development of atherosclerosis, which can lead to stroke. Now coming to dyslipidemia management. So besides the blood pressure, hypertension, diabetes, as I told you, the dyslipidemia, that is abnormal cholesterol levels, should be controlled by changing the lifestyle measurements or by using the statin therapy. So depending on the patient to patient, so there are certain criteria have been laid down, but the basic concept is to control the dyslipidemia so that we can prevent the progression of atherosclerosis in these cases. And there is a level B class 1 evidence that it prevents the stroke in all cases in which who are high risk cases or even the patients who are intermediate risk cases. So patients who are having TIA in all those cases, or patients who are having stroke and other comorbid atherosclerotic cardiovascular diseases, they should be managed according to the AHA 2018 guidelines, which include lifestyle management and the medications according to the requirement, according to the guidelines. There is a class 1 level A evidence, and more recently NCP 83 guidelines were modified to include the therapeutic option of reducing the LDL cholesterol even less than 70 mg/%, especially patients who are of high risk cases or moderate high risk cases of developing atherosclerosis. So this is the guidelines by which we can measure the risk factors in patients who are having high LDL cholesterol, and we can move forward according to the levels. So patients who are moderately high risk cases, in which usually the LDL cholesterol should be the target is less than 100. In very high risk cases should be less than 70, and patients should be treated with the statin in all these cases, irrespective of the lipid profile. I will not go in detail about ATP 3 guidelines because of the shortage of time. So these are the statins which are commonly used. So these are the medicines which are commonly used to control the dyslipidemia, to prevent the brain attack or heart attack. The statins are commonest in use, but patients who are not able to control, in which we are not able to control the statin, the other therapies like ezetimibe, fibrate, and now the PCSK19 inhibitors can also be used in selected group of patients. Now antithrombotic therapy, that is use of antiplatelets. So there is a big controversy many times whether we should use antiplatelets or aspirin as a preventive drug in patients to prevent the brain attack or not. So answer is no. So patients who are having diabetes, it has been seen, lot of, I think 7 trials have been done till now which have shown that the aspirin uses for preventing the stroke leads to more harm than the prevention. But aspirin in a low dose can be used for the other purpose, for the prevention in patients of diabetes with atherosclerosis, but for the stroke the data is still lacking. Patients who are developing a stroke one time or TIA, in those cases there is a definitive role of using the antithrombotic drugs. So there is a level A class 1 evidence that we should use antithrombotic drug, either the aspirin or clopidogrel, and in the patients who are having mild stroke or TIA, in those cases there is a role of double antiplatelet drugs. The Explorer trial has shown that we can use the double antiplatelet drugs in those cases, and especially who are having mild stroke or TIA for 3 months and followed by the single antiplatelet drugs. Now the secondary prevention. So once the patient has developed a stroke or TIA, so especially the TIAs, so there is also a question many times is raised in the front of the physician as well as for the neurologist. Patient coming to our OPD with a TIA, transient event, focal deficit, and recovering within 1 hour or less than 1 hour or 2 hours, whether we should admit the case or not. So there is a beautiful studies conducted to see whether the TIA patients require admission and require aggressive treatment or not. So there is an article published in Lancet in 2017 which have shown that the patients of TIA in that study, they've done the risk stratification, and they have devised a score known as ABCD, which is very good even for the physician to know that this is based on the California score. And in this, if you see, there is A means age, which is more than 60, there is a 1 point given. B for blood pressure, if it is more than 140/90, then 1 point given. The C for clinical unilateral weakness, 2 points. Speech without weakness, 1 point. The duration, if it is 10 to 59, less than 1 hour, it is 1 point. If it is more than 1 hour, 2 points. And diabetes, 1 point. So if the ABCD score, it has been seen that 3 or more than 3, then chances of developing further progression to stroke are very high within a week. So in those cases, if the ABCD score is 3 or more than 3, patient should be admitted in the nearby hospital for this and start the double antiplatelet drug unless there is some contraindication, and investigate the case to know the reason for the etiology for the TIA. Rest of the cases can be managed at home. So that's a crux of the study which is published in Lancet. There is an express trial in which they have seen that 80% reduction in the risk of early recurrent stroke in patients who are treated with the double antiplatelet drugs, especially patients who are having a mild stroke and TIA. Certain patients who are having active fibrillation, in those cases, the prevention is done by using the anticoagulation drugs. Earlier, the anticoagulation drug which is used is all of you know about the vitamin K antagonist, that is warfarin or the acetron. But nowadays, the warfarin is still in use, especially patients who are not able to afford or in which the indication of newer anticoagulation drug, novel anticoagulation drug cannot be given. So in those cases, still warfarin can be used like patients who are having severe mitral stenosis, patients who are having the cortical venous thrombosis. In those cases, warfarin is still a drug of choice. So, but on the basis of CHEST FES score and HAS-BLED score, we can start the novel newer anticoagulation drug, which include the dabigatran, rivaroxaban, or the apixaban, which are available in Indian market. So this is an algorithm which can be used for starting the anticoagulation like CHEST FES score in male if it is 1 or more than 1, or in female if it is 2 or more than 2. In those cases, there is a clear-cut indication, there is a level A and class 1 evidence that we should use novel anticoagulation drugs for prevention of stroke. And this is a patient of 110 years which came to me with a left MCA stroke with the AF, and PTCA was done, patient had developed a stroke, and patient is on apixaban for last 3 years. This shows that age is no bar unless there is some contraindication for using the novel anticoagulation drugs. Now regarding the diet. So diet and nutrition is a very important part of lifestyle management for primary prevention of stroke or brain attack. And reduce, so it has been there is a level class 1 level A evidence that reduced intake of sodium and increased intake of potassium is indicated in the dietary guidelines of American Academy of Cardiology as well as American Heart Association for lowering the blood pressure. A DASH style diet with emphasis on fruits, vegetable and low fat diet is good for prevention of stroke as well as hypertension. So Indian vegetarian diet is very good in that context, and there is a level A class 1 evidence. This is a beautiful trial which is a HOPE 3 trial. I just tell you short, which was done for prevention of again stroke, and in this trial they have taken a patients who are having a medium risk factors. So the patients who are having a increased waist height ratio, smoking, low LDL, low HDL, dyslipidemia, dysglycemia, or mild renal dysfunction of family history of CSD, they are included in the study, and they have seen basically they have measured the cardiovascular death, MI, stroke as a primary target, as a primary goal in these cases. And there is a large number of patients, more than 4,000 patients are included, and they have given candesartan as well as the rosuvastatin 10 mg per day in these cases. And they have seen, the data have shown that there is a remarkable decline in the coronary heart disease, stroke after using the combination of antihypertensive. So these are the diagrams you can see here. There is a significant p-value showing that the remarkable decline in the stroke and coronary artery disease in all these cases who are using the candesartan antihypertensive or patients who are using the statin, rosuvastatin with the risk factor which I have told you. So clinical implication of the study is that statins are beneficial to all the participants. Blood pressure lowering benefits only the patients who are having a 140 systolic high blood pressure. More than that, combination therapy leads to more than 40% risk reduction in controlling the stroke as well as the blood pressure. So the pragmatic strategy is required in all these cases. Patients who are having metabolic syndromes. So if you see here that if you see our evaluation that we are having less obesity and now having a increasing obesity all over world, and having many of these cases are having a metabolic syndrome. So all of you know as a physician about metabolic syndrome, but if you see here that abdominal obesity, so there is basically in the metabolic syndrome there is obesity, there is a high blood pressure, the fasting blood sugar is more, and there is a dyslipidemia in most of the cases in form of HDL cholesterol less than 40. So in all these cases, they are very much high prone to develop a stroke, and all these cases require a lifestyle management and followed by, if the indications are there, then starting the statin therapy, controlling the diabetes, hypertension aggressively in all these cases. And you can reduce, it has been seen that data has shown that we can reduce the incidence of stroke or brain attack in all these cases. The basic cause of this metabolic syndrome or obesity is our lifestyle. You can see here that even if you eat a cheeseburger, there is a 1000 calories. If you do the exercise, if you are doing a 2 hours walking, then you just spend hardly 400 calories, hardly 400, 300, 400 calories. So eating is very, very easy, gaining calories very, very easy than spending, and so due to the changes in our diet, so even if you are walking for 2 hours 20 minutes, you are losing just 400 calories. You can see that. And if you are eating just a cheeseburger, you are gaining more than 1000 calories. So it is very difficult to lose calories than gaining calories. This nature has given like this. Nature has. So I think that's why today's theme that prevention is always better. And so nowadays the visceral adiposity, which is very common in Indian population as compared to Western population, is more dangerous. And many of the people in India, they are having thin arms and legs but having a abdominal obesity, which is very dangerous. So waist height ratio or even the total waist circumference is also important to know the abdominal fat, which is one of the risk factors. And the why it occurs, because if you see that prevention starts, I believe, from the childhood. That we as an Indian from childhood have very less, you can say, physical activity as compared to the Western population. And Western population from the childhood, they have a lot of exercises, lot of physical activity, but we are not doing it enough from childhood. So prevention should be started from the childhood, and this is very pertinent, especially in Indian population. Then only we can prevent the brain attack or stroke and the other heart-related diseases. So prevention of the brain is very, very important, and the time is whenever the patient develops brain attack, the time is very, very important. We should reach in time, especially within 6 hours, and nowadays in selected group within 24 hours we should reach to the hospital to prevent our brain. Thank you.
Some important insights into prevention of stroke. You mentioned, just one question, you mentioned about aspirin being used as a prophylactic, and there has been a trial, the famous live trial, which had said that aspirin, even in cardiology, to prevent cardiac events, is not a very good idea because it leads to more complications than it solves.
I've said that.
So what about, is it true about stroke also?
No, that's I've clearly mentioned. The trials have shown that the aspirin is not preventive for the brain attack at all. I have told. So trials have shown that aspirin leads to more harm than the prevention, than the benefit, especially in prevention of stroke. So it is not useful. Even in diabetic patients, in high risk cases, unless patient is having atherosclerotic event, cardiovascular event, then only aspirin should be used, otherwise not.
And of course, there is no argument about the secondary prevention. Role of aspirin in secondary prevention.
There is no argument.
There is no argument.
Yeah, for the secondary it has to be given.
Any question, Lalit? Want to ask any question?
Thank you.
Just a minute. I would request Dr. P.K. Gupta sir to felicitate Dr. Puneet Agarwal sir with a certificate and with a gesture of gratitude from Dr. Sushil. Thank you so much sir for agreeing to be a part of